Thank you, Abdullah. And good evening, everybody. I know it has been a very long day for all of you, so I try to be as as short as possible. This is my disclaimer. Now, the treatment of heart failure. I'm sure you have heard a lot. You are going to hear more tomorrow. Nobody can actually deny the effect of these 4 pillars in the management of heart failure. The evidence and the speed of discovery and recommendation is nothing like what I have seen before. So it all started with consensus long time ago. I remember, I'm sure some of you also remember as well. And we progressed to even reach to Arnold and interest I have here. Thank you. Yes, thank you. And during all of these clinical landmarks, trials, and the clinical practice that we had, we learned so many things about the pathophysiology of heart failure that includes the RAS inhibitors. And we learned that when you prescribe RAS inhibitors, the dose is very important. The up-titration is very important. It's very important to combine all of these pillars together. We even learn that sometimes we should not combine the pillars together, like with ACE inhibitor and ARBs. And we learn that if at one point during the therapy we force to decrease RAS inhibitors or to stop it, that's usually a bad news for our patient. So one of the main reasons that we do that, we decrease the RAS inhibitors or we stop it, is the issue of potassium. And if you have practiced treating heart failure patients, treating diabetic patients, treating patients who live with chronic kidney disease, you know that it is not infrequent. Then we see the lab and there is hyperkalemia and what to do with that. And unfortunately, this hyperkalemia occurs in patients that by definition, and the very good fruitful discussion that we just had, patients who actually tend to get more benefit with the even a small dose of ACE inhibitors and a slow up titration of ACE inhibitors. So how we treat hyperkalemia in common practice, in daily practice? Well, in a country like UAE, when most of our patients love dates, they love mangoes, we usually ask them to restrict their high potassium dietary components like dates and mango. But we know it's usually very, very difficult because most of our patients are elderly, and usually elderly are not very cooperative in restriction of their diet. Of course, the other thing that is even quicker for action is either to reduce RAS inhibitors or to discontinue it. Then some will use diuretics, non-potassium sparing diuretics, sodium bicarbonate also, and then we have traditional potassium binders that has a lot of GI side effects and patients usually don't like to take it. So what is new in the management of hyperkalemia for patients who live with heart failure and patients who have chronic kidney disease? And that is the novel binders in the management of hyperkalemia. And currently, at least in UAE, we have 2 agents. We have sodium zirconium and we have patiromer. In general, both of them, they work very well. In general, they are not there to be another pillar for heart failure management. We already have 4, and it will be great if we use these 4. These agents are there for us to enable us to use these 4 pillars of the management of heart failure. So for the sake of the symposium, I'm going to talk to you about LOKELMA, which is the sodium zirconium. It is the mode of action of this agent. It is a preferential potassium binding in exchange for sodium and for hydrogen. It works very quickly, as early as 1 hour after the first dose, and it has efficacy which is maintained over 1 year, which has been demonstrated in the clinical trials. It has a limited effect on the function or binding to other medication products, and it works and binds to potassium throughout the GI tract, and that's why maybe it has less GI side effect. The recognized side effect of LOKELMA is hypokalemia and edema-related events that we are going to go back to that after a few minutes. So this sodium zirconium, which has a very nice name, by the way, is inorganic crystalline zirconium silicitate component. It is not a polymer. It is insoluble and it is highly stable and does not expand in water. So the maintenance and the storage of the medicine, it's easy. You don't need to keep it in a certain temperature. It is not systemically absorbed, so the side effect is less than the other component. It has a very high affinity for potassium with exchange with sodium and hydrogen. So based on the vitro data, the sodium zirconium may begin working immediately in the small intestine after digestion to preferentially capture the potassium, and potassium is exchanged with hydrogen and sodium throughout the GI tract and large intestine as well. Well, since the development of the sodium zirconium, it has been tried and practiced in different scenarios. Patients with chronic renal failure, patients with diabetes, elderly patients, and patients who live with heart failure. These are the patients' population that we can see more and more hyperkalemia when we do the lab test for them. And of course, all of these categories of patients have been included in clinical trials, and that makes it more efficient in the clinical practice, because all of you treating heart failure, you want to uptitrate RICE inhibitors or ARNI or Aldactone. So it gives you a free hand to do that without producing hyperkalemia. One of the trials that I'm going to mention is Harmonized Trial, and this included 44 nephrology and cardiology and general research sites, mainly in US, but South Africa and Australia was included as well. The criteria for inclusion criteria was a potassium more than 5.1. The new guidelines of the European Society of Cardiology defines the potassium of 5 to 5.5 as the mild hyperkalemia, 5.5 to 6 as the moderate hyperkalemia, and above 6 of severe hyperkalemia. So the patients had a 48 hours correction phase with a dose of sodium zirconium of 10 gram TDS, and then we have 28 maintenance phase for the patients. Now, what it showed that, and this is very significant and very important, that the 1 dose of sodium zirconium significantly reduced the serum potassium level at 1 hour at the baseline. And about 98% of patients achieved the normokalemia during the 48 hours correction of the hyperkalemia. And you can see in this graph that how the mean serum potassium level with sodium zirconium 10 gram 3 times daily for 48 hours actually reduced the potassium. The comorbidity of the patients who were included in this trial was chronic kidney disease patients, type 2 diabetes, heart failure, and about 70% of patients actually were taking RAS inhibitors. Now, sodium zirconium also consistently reduced serum potassium regardless of the comorbidity of the patient had. So it's important for us that I should not think whether this medicine will work on diabetic patients or it will work with patients with chronic kidney disease or with heart failure. It demonstrated that it can work on all of this patients' population. And it demonstrated that it can work in whatever the initial serum potassium was. So the effect and the reduction of serum potassium was not actually dependent on the initial serum potassium. At the sustained potassium control up to 1 year, about 88% of patients maintain an average serum potassium of less than 5 over 11 months. And the side effect also was in favor of sodium zirconium. There was no dietary restriction which was imposed on patients, and patients were instructed to continue their usual diet without any specific alteration, which is important for all the patients. And you can see all of this in the 3 phases: the correction phase, the maintenance phase, and the extension days. So during the extension phase, about 78% of patients maintained the same dose of the RAS inhibitors, and the reduction of the RAS dose was minimal to 8%. Even some patients, they had other agents to be included in their management. The other study was an open label study. There was no placebo arm in this study. And it was outpatient patients with serum potassium of more than 5.1. Patients were included from 56 sites from cardiology and nephrology clinic, again in US, Australia, Germany, UK, Netherlands, and there was no dietary restriction. And you can see that the serum potassium nicely came down, and we had a good translation into the maintaining of the RAS inhibitors for their therapies. Now, going back to the name, sodium zirconium, you always remember sodium. And you know, maybe you have heard that sodium zirconium can cause sodium retention. Yes, it can cause sodium retention. It has been observed in some of the patients in the clinical practice. But I want to bring your attention that how many of us actually prescribe paracetamol? In the paracetamol, there is 854 milligrams of sodium, whereas in the sodium zirconium of 10 grams, which is the usual dose that we use in clinical practice, the content of sodium is only 800 milligrams. So the sodium retention has been observed in the clinical practice mainly with the dose of 15 grams and above that usually are not used in the maintenance phase of patients with hyperkalemia. And the edema which is produced with that is usually very well respond to the diuretics, which is usually a main component of patients with heart failure and with chronic kidney disease. Sodium zirconium has one advantage of the patiromer, and that is that it was practiced in patients who are on hemodialysis. So dialysis trial was conducted for patients on dialysis, and the starting dose of the sodium the sodium zirconium was 5 grams on non-dialysis day, and then gradually it was increased. And you can see that the potential response for the reduction of the potassium was was in favor of the treatment arm compared to the placebo. And more patients receiving sodium zirconium had a serum level of maintaining of the serum potassium between 3.5 to 5.5 during the dialysis. And the weight gain and the marker of sodium and fluid retention was similar between the treatment arm and between the placebo. So sodium zirconium did not actually produce more edema and sodium and fluid retention for patients who were on hemodialysis. Most of the side effects reported for these patients were mild to moderate in intensity. The pre-dialysis hypokalemia was comparable between the two arms of the active treatment and placebo. The most common side effect was GI orders, with no significant difference between the two groups, and there was no clinically meaningful change in the blood pressure, and most of the side effects were considered not related to the study drug, because all of you who have done research, the smallest side effect or complaint that patient has, we have to actually report it, and then at the end we analyze it and say it was related to the active component or not. So the safety and the tolerability profile in the clinical trials of sodium zirconium, about 5.7% of patients receiving LOKELMA reported edema-related events, but this is mostly commonly seen with patients who are taking 15 grams, and it is not approved to use in the EU, this dose. No clinically significant changes in the urinary sodium excretion or the serum magnesium and calcium level. About 4% of the patient developed hypokalemia, which was resolved with the dose adjustment or discontinuation of the LOKELMA. In the clinical drug interaction, a study conducted in healthy individuals, this co-administration of the LOKELMA with the amlodipine and clopidogrel and atorvastatin, furosemide, and all the medicine that we commonly use in cardiology, there was not resulted in any drug-drug interaction. It is not systemically absorbed or metabolized by the body. It can transiently increase gastric pH, and therefore it should be administered at least 2 hours only for the medicine which are pH dependent, and they are mainly oncology medications. It can be co-administered without spacing or dosing time with oral medications who do not exhibit pH dependent bioavailability like oncology treatment. So if we want to compare these two components, you can see that the LOKELMA has a rapid onset of action, as quick as 1 hour, whereas patiromer has delayed onset of action within 4 to 7 hours. As I mentioned, it can be taken with most of the other medications together. There is no restriction of the food with it, and because of its stable component, it's easier to be stored compared to patiromer. And it is well tolerated, and it has, because it is a highly selective inorganic insoluble that prefers the potassium binding in exchange for sodium and hydrogen over calcium and magnesium. So overall, both medications are quite safe and quite useful. And if the potassium falls below the desired range, the moment Dr. Abdullah walks, it gives you palpitation. So the dose should be reduced 5 grams every other day, whereas it's a little bit more complicated with patiromer. If the patient has missing dose, we usually ask the patient to take the next usual dose at their normal time. And it has been well studied in patients who are on hemodialysis. I want to tell you one thing. Both medicine are very effective. Both of them are very safe. Both of them are there. I actually loved the lectures that was presented in Madrid for the Heart Failure Association. This is enabling medicine. So it enables you to treat cardiovascular disease, mainly heart failure with chronic kidney disease, according to the guidelines and using the 4 pillars of the management of heart failure. So the correction phase of the treatment, it is usually 10 grams for 24 to 48 hours, and then we have the maintaining dose, which is usually 5 grams. And in the dialysis patients, we usually tend to use it on non-dialysis days. So as I said, this is enabling medications. It actually allows you, cardiologists, to dive through the guidelines of the management of heart failure patients and to use ACE inhibitors, ARNIs, aldactone, beta blocker, and SGLT2 inhibitors in a safe way. Thank you very much.
Excellent. Thank you very much.